Please join me in welcoming our newest member with pride, Dr. Darshan Brahmbhatt.
Thank you very much, Dr. Barley. It's a tough assignment to follow Dr. Flores. And he mentioned about some of the research being countermanded by this other group who used the wrong type of device. That's where I did my PhD. So we were reading his papers weekly. And never did I think I'd be on the same agenda as Dr. Flores. So it's a real privilege. So I'll talk a little bit about my work in digital health innovation in heart failure care. A little bit about myself to start off with. Yes, I trained in Cambridge, and the gargoyles are the specialty of the college that I trained at. Look very carefully. They double up as drain pipes. And I very much like the Hall of Chairs. And back where I trained there for maybe 12, 14 years, we had all the photographs and latterly paintings of all of the different people who led the college. And if you look really carefully, you might recognize one of the people who was the only person who didn't lead the college, who had his own portrait put up in the middle of the hall. If you ask very nicely, when I'm doing the tours later, I'll tell you some interesting stories about how Professor Hawking's wife managed to switch places with my then girlfriend, now my wife, at one of our formal dinners. So I did all my training in the UK, cardiology, internal medicine, largely based around Cambridge. I went to London to do my PhD in digital health. And in 2019, I planned to come to Toronto. It was only going to be 9 months. I've come to steal the secrets of Toronto and take them back to the UK, explaining how we could do things better. That was the plan. COVID happened, and being in this room brings back some terrible memories, because actually this is where I had my first ever COVID test. I think I was in that corner over there. So anyway, 1 year became 2. And then when a colleague left, they said, well, actually, this might be the right place for you. I looked around and I was like, actually, this is a really nice place. Patients really like it here. I could see myself here. My wife was supportive too, which was the most important thing. So now I work here at Sinai as a heart failure doctor. I was told when choosing a career, make sure you choose something that you can boast about. You can go into a bar and tell everyone what you do. And he said, whatever you do, don't become a urologist. So a friend of mine who's a neurologist, the pointing is really important because people never understand what you're doing. I walk into a bar and say, I get to mend broken hearts for a living. And that works pretty well. So that is what I do. We look at the heart on the left, and it's a terrible, sad, upset heart. And using medicines, using therapies, we try and make them better on the right-hand side. You've heard from a number of my colleagues who talk about heart failure and just how awful the symptoms are. People can't breathe. It feels like you're drowning. You lie down too far and you wake up all of a sudden short of breath. It's atrocious. People walk a few steps. Some can't even walk steps. But we have a whole heap of treatments, medical treatments, that can make people better. What's the other part of my work? I love technology. I realized that actually medicine was designed for physicians. The way we hold office hours, the way patients come to us, the way everything is organized. And I was like, well, maybe we could make medicine better by improving the technology to help us bridge that gap between patient and therapy. And when I ask people about technology, everyone thinks, something like this, second F1 car you've seen today. This is a great car. If I asked anyone to define what's the best car that's going to get you to anywhere you need to be, it's probably that. It's driven by a 7-time world champion. It's Mercedes, it's everything. It's great. But actually, when you put it into test in this sort of environment, that car is useless. And for too long, we've had engineers and physicians go, technology is great, enthusiasm for technology, never actually looked at where we're going to use it, how we're going to use it. So my research was in implementation science of digital health and making sure that we bridge the gap between technology and how we use to deliver it to provide care, because that's what we want to do at the end of the day. So one of my colleagues here at Sinai, Michael McDonald, he wrote the Canadian guidelines for heart failure. Very busy slide, but the really important thing is right at the top. We have not 1, not 2, not 3, but 4 therapies that make people's lives better, reduce the risk of death, hospitalization, and improve quality of life. If you look at this graph, again, it's very busy, but the line in the middle, the black line, is unity. That is where if you gave no one no treatment, that is the outcome you get. The further you get to the left, the better it is, the reduction in death and mortality. And you can see from the bottom upwards, as you add one drug, a second drug, a third drug, get all the way to the top, you actually have a 60% reduction in death. That is one of the most impressive things. There are very few treatments out there that are so effective. We have that. So why bother? Why do we need me? We don't need me. Actually, here's the real tragedy. Despite having these treatments that for a 50-year-old can give them an extra 7 years of life, for a 70-year-old can give them an extra 5 years of life, overall, in a recent American survey, 12% of people actually receive these medicines. We have the therapies, we've just not managed to get them into the patients. When you look at getting to the right dose of the medicine, it's only 4%. So there's a real big bridge between what the research shows us, the wonderful developments we have, and how we get them into patients. So I'm going to share a trial that we ran here in Toronto, where we used a monitoring platform called Medley. This is usually used to help people stay at home and not become deteriorated with heart failure when their weight goes up and they start collecting fluid. It's an early warning system. We said, actually, we could use the data that the early warning system collects, which is blood pressure, heart rate, symptoms every morning, and we could then use that to guide decisions on improving treatment. So not just keeping people out of hospital, but actually improving how they do. So we ran a randomized controlled trial, and it wasn't very big, but it was big enough to show the effect. And instead of people coming to clinic on a Tuesday afternoon, having their blood taken, their blood pressure taken, an interview with the doctor, prescription of medicine, and then 2 or 3 weeks later coming back, repeating the whole process for each one of these increases in medicine, we said, right, let's save them the 1.5 hours of traveling from 2 miles away in the Toronto traffic. Let's save them the $25 paying for parking. If you're working, you've got to take half a day off work. Some of our patients can't afford that. If you're older and need some support, someone else needs to take a day off work. Let's stop all of that. What we'll do is we'll use all the data they're giving us anyway, and every 2 weeks, we will remotely tell them to increase their medicine. We can ring their pharmacy or email their pharmacy, prescribe their new medicine. So we did. And when you look at the success, it was really striking. The blue line is usual care. And if I can show you here, if you look at 50%, it takes about 6 months to get there. With our technology, we got there in 4 months. Amazing. More importantly, and I think this is the crucial part, if you go out to a year, so somewhere around there, 25% of people still haven't got to target. Reading Mike McDonald's guidelines, he says you should get there within 3 months. At a year, these life-saving medicines aren't in people, but if you use the technology and support the patients, you can do that. So that's what the plan is. We have a wonderful heart function clinic. We have the right type of patients. We can run studies very easily to ensure that when technology is developed, it's used properly. So, Dr. Mack told you earlier about the cardiac catheter lab, and the work that's done there is world-class. End of story. And I can say that because I'm boasting on behalf of someone else. The work there is the gold standard. And while it's really useful and really helpful, it's still invasive. You'll still need a tube put in through your neck or through your groin, and we'll show you the tubes that we put in when you come on the tour. Wouldn't it be better? What if we could get that same information without having to do an invasive test? Well, actually, there's a company that's devised a new platform. It uses a mobile phone with 4 pairs of sensors. Looks at seismic activity, sound activity, vibrations, noise, ECG. And the plan is you just put it on the patient's chest, and it gives you, within 30 seconds, the same information, supposedly, that the gold standard that Dr. Mack does. Now, in technology, in health technology particularly, beware of snake oil salesmen. They're everywhere. Everyone wants to tell you that this is the new thing, this is going to be the greatest thing, and we need to make sure that these hold up to true scrutiny. So why not come to the best place in the world to do these studies? And that's what they did. They came and said, we want to compare our technology to the gold standard, and they actually extended the study just so they could recruit more patients from Sinai. We were the largest Canadian center with over 80 patients, and over, I think, 1,600 patients worldwide were recruited. So we wait the results, and we'll publish this, but we need to make sure that it's effective in our patients, and then how we use them. I'll leave you with one last thing. This uses a lot of machine learning and AI, And everyone says that's the future of healthcare. I started at the beginning saying that we practice for physicians or clinicians or hospitals. Most people don't get sick Monday to Friday, excluding holidays, between 9 a.m. and 5 p.m. That's not when they want advice. That's not when they want support. So
Hello.
we've developed this.
My name is Darshan. I hope your day is going well. I want to start by saying that I'm an automated assistant. Are you okay to go ahead? If not, you can just hang up.
It was originally Dr. Ross, our division chief voice that was used here, but they wanted a more soothing, calming voice, and so they stole mine. But this is an interactive, voice-activated phone chatbot. We'll do an avatar, doing a video one later. But if you need advice at 3, 4 in the morning and you don't know where to turn, this is a well-trained, it's only going to provide safe advice. And as the patient asks questions, press play again. As the patient asks questions, it then responds appropriately.
Let's do this. Thanks, Darshan.
Great. So how have you been feeling lately? Any changes in your symptoms?
Well, yeah, I'm calling because I've felt a lot of swelling in my feet, ankles over the last week. It's very uncomfortable.
I'm sorry to hear that. Swelling can be really uncomfortable. Have you noticed if the swelling gets worse at certain times of the day?
Yeah, it seems worse at night, in the evenings.
And eventually, at the end, summarizes the whole clinical encounter, sends a copy to the patient, saying this is what we discussed and these are the recommendations, and then provides a copy to the clinic. So next morning when we come back into work, because we can't be available 24/7, you now have a record of what advice has been provided. Now, this helps break down the barriers to make sure our patients can get access to care when they need it. And we are going to be the place to test out all of the new technologies that are coming forward. We've got 2 studies in the pipeline, and they will continue to come. So I'll stop there. Thank you very much.